Welcome to the UC San Diego School of Medicine Ultrasound Series for Medical Student Education. This module is intended to introduce the student to ultrasound. We will begin by discussing a brief history of ultrasound and present physics concepts that are essential in training the novice sonographer. Next, we will discuss the use of ultrasound equipment, including hardware, transducers, and various modes of scanning. As the student becomes more comfortable with the equipment and understands the relevant physics, we will further discuss image acquisition and artifact, which may occasionally complicate the understanding of the image on the screen. Lastly, we will discuss the bioeffects of ultrasound. By constructing a strong foundation of basic ultrasound concepts, the student may maximize the effectiveness of the other modules in this series. Some animals emit sound waves into the environment and then listen to the echoes of those calls to help locate and identify objects. This is referred to as echolocation. Examples of echolocating animals include bats, dolphins, and killer whales. Echolocation is used for navigation and foraging, as illustrated in the diagrams. The concept of animal navigation using the sense of hearing was first theorized in the late 18th century. Early experiments with bats demonstrated that they were able to maneuver in the dark even when blinded. However, they were directionless when the sense of hearing was impaired. In 1826, the first documented experiment to record the speed of sound in water was performed using an underwater church bell. The speed of sound was estimated to be 1,435 meters per second, which is actually close to the currently accepted value for the appropriate lake temperature. In 1842, Christian Doppler published and presented his work on the color of the stars. He hypothesized that the frequency of a light wave actually shifts when the source of the wave or the observer moves. The same is true for sound waves. This principle was later named the Doppler effect and is illustrated in the video clip at the bottom of the screen. The car emits a sound wave. As the car moves to the left of the screen, the observer on the left will experience a higher frequency sound wave. Meanwhile, the observer on the right will experience a lower frequency sound wave. The Doppler effect is used in modern ultrasound machines to analyze blood flow using different forms of Doppler imaging. This sound clip demonstrates a car emitting sound from its horn. Note that as the car passes by the listener, the frequency changes from high to low. The Curie brothers, pictured on the right, first demonstrated piezoelectricity in 1880 using a quartz electrometer. Piezoelectricity refers to the appearance of an electric potential when a crystal is compressed. This is an inherent property of certain solid materials, such as quartz. This concept is illustrated in this diagram. The crystal has atoms arranged in a very orderly fashion. Although the arrangement of these atoms is asymmetric, the overall electrical charges within the crystal are electrically neutral. When the crystal is compressed, the net charges become unbalanced, releasing an electric potential. Positive and negative charges appear on opposite ends of the crystal. This is a demonstration of the piezoelectric effect. 1 year after describing this effect, the Curie brothers also confirmed the reverse piezoelectric effect, which states that crystals could be made to deform when subject to an electric field. Overall, this was a revolutionary finding which was the basis for the creation of modern ultrasound transducers, which contain piezoelectric crystals within. Other historical events such as the RMS Titanic disaster and the arrival of World War I prompted research into the development of equipment to improve water navigation. The first piezoelectric transducer to detect submarines underwater was developed by French physicist Paul Langevin in 1917. The hydrophone, illustrated on the right, consists of quartz crystals glued between steel plates. This work was the precursor to modern-day sonar. The use of ultrasound in scanning bodily tissues was first experimented with and published in the late 1940s. The initial experiments were conducted on animal subjects. In the early 1950s, Dr. John J. Wild and his collaborator John Reed developed the echoscope, which was the first clinical ultrasonic scanner. The device was able to translate ultrasonic signals into visual images. The initial publications described its use in the evaluation of breast tissue. By 1955, however, Dr. Wild was already well ahead of his time, creatively foreseeing a variety of applications using ultrasound in the clinical setting. Other groundbreaking publications in diagnostic ultrasound include the use of ultrasound to record heart wall motion and in the investigation of abdominal masses. Over the next 20 years, as research continued to emphasize the potential medical uses of ultrasound, the manufacture and commercialization of ultrasound machines began to expand. The refinement of two-dimensional imaging allowed the first 2D scanner to be available in 1963. The first commercial real-time 2D scanner was manufactured in 1965. By the mid-1970s, grayscale imaging was beginning to evolve as well. The first portable scanner was released in 1975, weighing 25 pounds. The image display consisted of only 16 shades of gray. In comparison, modern-day ultrasound machines display over 250 shades of gray. Here, we are able to witness the effect of technological advances in the resolution quality of ultrasound images. Over the years, advances in technology have also enabled manufacturers to market machines with newer software features, increased machine durability, and smaller size. Here are some examples of cart-based systems, which are often used in emergency department and various hospital clinic settings. The top row of photos in this slide are examples of laptop-sized machines, which are easily folded and carried by hand. These battery-powered machines can additionally be convenient for use in resource-limited settings. The bottom row of photos demonstrates portable machines, which utilize touchscreen technology. The pictured machines were used abroad by several of our physicians from UC San Diego. Handheld ultrasound devices continue to be a focus of research and development for several manufacturers. Newer machines with improved resolution and increased versatility are expected to arrive on the market in the near future. Additionally, several ultrasound products are also newly available on the market which no longer require an actual machine. Instead, the transducer is able to directly connect to one's cell phone or laptop USB port, which contains software to view the real-time image. Sound waves, like all other waves, are measured in units of frequency, or hertz. The human ear is able to detect sounds at a frequency range from 20 Hz to 20,000 Hz. Ultrasound is defined above the human hearing range, or greater than 20,000 Hz. Medical diagnostic ultrasound, on the other hand, involves waves that are emitted and detected at much higher frequencies, between 1 MHz and 20 MHz. Medical diagnostic ultrasound is defined as an imaging technique in which high-frequency sound waves are transmitted into the body with the use of a transducer. The ultrasound waves reflect from tissues and organs of varying density. The transducer picks up the returning echoes, and the generated data is used to create an image of the structure. As illustrated here, there are a variety of ultrasound transducer types. Each transducer varies in its frequency range and its applications. A wave is defined as a disturbance that travels through a medium from one place to another. An example of a wave being created is a speaker, which converts electrical energy to mechanical energy. This results in the vibration of air molecules, which then transport sound energy. The medium in this example is air. The air particles which comprise the medium oscillate, creating zones of compression and rarefaction. Note that although the air in the medium transports the wave's energy, the air particles are not transported from one place to another by the wave. In other words, waves do not carry matter from one place to another. Rather, waves simply use the particles in the medium to transfer energy. Similar to the speaker on the prior slide, An ultrasound transducer is also capable of creating sound waves. Additionally, the transducer also has the capability of picking up echoes which return back to the probe. The piezoelectric elements within the transducer were traditionally made of quartz until the discovery of synthetic materials which offered further advantages. The modern ultrasound transducer contains a synthetic ceramic called PZT. The direct piezoelectric effect is illustrated on this slide. Note the ultrasound waves on the right panel. As these waves return from tissues to the transducer, the crystal in the transducer changes shape. In this diagram, the returning sound waves cause the crystal to compress, resulting in an electrical voltage. The amplitude of this voltage varies depending on the strength of the returning echoes. For instance, a tissue such as bone is generally highly reflective and results in the return of a high-intensity signal. Hence, it is referred to as hyperechoic. Tissues that reflect lower-intensity echoes are referred to as hypoechoic. Tissues that do not reflect any echoes are referred to as anechoic. We will discuss all of these terms again later in this lecture. Overall, the body's tissues and organs cause a variety of different echoes to return to the transducer. The result is varying shades of gray, which comprise the image on the screen. Hence, this is referred to as grayscale imaging. The indirect piezoelectric effect is illustrated on this slide. Note the alternating current is applied to the crystal, which causes it to change shape. The crystal vibrates at a high frequency. Overall, the indirect piezoelectric effect, in essence, describes the creation of ultrasound waves. The alternating electrical current affects the crystal, and high-frequency sound waves are thus produced and transmitted into the tissue. Sound waves are mechanical energy which can be carried from one molecule to the next. The propagation of this wave requires a medium, such as solid, liquid, or gas. Hence, sound cannot travel through a vacuum. Sound waves are examples of longitudinal waves. In the animation, the direction of the wave is indicated by the direction of the compressed particles. Hence, the wave's direction is left to right. However, each individual particle does not get transported from left to right. Instead, if you look closely, the individual particles are oscillating back and forth. This reinforces the idea that waves do not transport particles in the medium, despite transporting energy from one side to the other. This also reinforces the concept of alternating zones of compression, where the particles are in maximum density, and rarefaction, where particles are more spread apart. This slide visually demonstrates the difference between longitudinal waves and transverse waves. Note the direction in which the particles in the medium oscillate. This slide also demonstrates the difference between longitudinal waves and transverse waves. The frequency of a wave refers to the number of wave cycles per second. For example, if an ultrasound beam is created at 3 MHz, the wave produced completes 3 million cycles per second. Frequency is measured in hertz. The wavelength refers to the distance over which a wave cycle is completed, and is measured in meters. Notice the inverse relationship between frequency and wavelength. Velocity is defined as the distance a wave travels over time. A wave's velocity is constant for a given medium. In general, the velocity of sound in air is less than the velocity in liquids, which is less than the velocity in solids. Note that the velocity of sound in tissues is generally estimated at 1,540 meters per second. However, an important point to consider is a presumption made by the ultrasound machine. Most ultrasound machines presume that the velocity of the wave in all tissues is 1,540 meters per second. This presumption is actually untrue and will result in artifact when certain tissues are scanned in B mode. Acoustic impedance is a measure of resistance of a medium, or tissue, to the transmission of sound waves. More important than the listed equation is to simply keep in mind that tissues of higher density will demonstrate a higher resistance to the transmission of sound waves. This table allows one to compare the acoustic impedance for various tissues in the body. The ultrasound beam has a variety of potential interactions which may occur when encountering tissues in the body. These interactions include attenuation, absorption, reflection, refraction, and scattering. In the next several slides, we will discuss these interactions. We will begin with attenuation, which actually occurs as a result of the other mentioned interactions. The ultrasound wave is weakened as it passes through tissue because some energy is absorbed, reflected, scattered, and refracted. Absorption is the main form of attenuation. The particles in the medium that transmit these waves vibrate, causing friction, resulting in a loss of sound energy. As a result, heat is produced. High-frequency waves attenuate faster than low-frequency waves. Hence, lower frequency is ideal for scanning deeper structures. When an ultrasound beam strikes an acoustic boundary, part of the beam's energy is transmitted across the boundary, while part is redirected or reflected back. This reflection occurs when the ultrasound wave encounters an interface between two tissues that vary in acoustic impedance. When such a boundary is encountered, an echo reflects back to the transducer. As illustrated on the bottom right diagram, the angle of incidence equals the angle of reflection. Hence, to optimally scan the object of interest, keep the transducer perpendicular to the object of interest, allowing most of the reflected beam to come back to the transducer. Refraction refers to the change in direction of a wave at a tissue boundary when the beam is not perpendicular to the boundary. Based on the velocity of sound between two mediums, the refracted wave may move towards the center or away from the originating beam. Scattering is also called diffuse reflection and refers to the interaction of the ultrasound beam with objects or interfaces within a tissue that are smaller than the size of a wavelength. In other words, diffuse reflection occurs from a rough surface, causing waves to reflect in various directions, or scatter. This results in little reflection of sound back to the transducer from the object. Next, we will try to familiarize you with some of the equipment that we will use. First, we will discuss the ultrasound transducer. The transducer, also referred to as the probe, is composed of the probe head, the connecting wire, and the connector. The term footprint refers to the surface of the probe, which emits sound waves and picks up returning echoes. As mentioned earlier, the probe head also contains multiple piezoelectric transducer elements. To understand the orientation of the image on the screen, one must first learn to understand the orientation of the probe itself. The probe marker is found on the head of the probe. It is typically indicated by a ridge, a dot, or an LED light. Note that the probe marker corresponds to the indicator on the screen. The probe footprint should initially come in contact with a scanning medium that prevents air from getting between the probe and the area of the body being scanned. Typically, the medium used is ultrasound gel. Other products available to use as scanning media include acoustic standoff pads and endocavitary probe covers for the use of the endocavitary probe. Additionally, sterile probe covers with sterile gel are also available for sterile procedures. Let's discuss some transducer types. Shown here is the linear probe. The linear probe has a wide rectangular, flat footprint. The image formed on the screen will also be rectangular in shape. The phased array probe, in contrast, has a flat footprint which is less wide and rectangular in shape compared to the linear probe. An example of the image formed on the screen is shown here. This slide demonstrates the curvilinear probe. The curvilinear probe has a wide, convex footprint and is ideal for abdominal imaging as the probe typically allows the use of low-frequency scanning, allowing deeper penetration into tissue. The image formed on the screen will have a wide field of view. Lastly, the endocavitary probe has a narrow semicircular shaped footprint. Note the footprint and the on-screen image produced by the endocavitary probe. We will now discuss various modes of ultrasound scanning. A mode is the basic mode of ultrasound, which refers to the plotting of echoes as they return over time. This mode is now quite uncommonly used in modern medical sonography. Understanding the details of this mode are not necessary for the scope of our ultrasound course. However, it should be noted that the A mode forms the basis for B mode imaging. B mode, or 2D mode, refers to real-time grayscale imaging. As mentioned earlier, the transducer emits ultrasound waves by converting electrical energy to mechanical energy using a piezoelectric crystal. As data returns from the structures being scanned, a linear array of pixels is displayed on the screen, resulting in an image. The intensity of the echo that returns will correspond to a level of brightness. This still image illustrates how different tissues or organs are displayed in varying shades of gray. Hence, the liver and the kidney can be distinguished from one another. As demonstrated by the video clip, another function of B mode is to allow real-time scanning, or the ability to display motion in the field of view. When scanning in B mode, there are two major obstacles to consider. The first is excessive bowel gas, which tends to cause an irregular display of bright echoes, followed posteriorly by dirty shadows. This shadowing results in poor image quality. The second is superficial bone. Bone that is superficial or just under the skin can also result in poor image quality. An example is rib shadowing. Note the highly echogenic smooth contour of the rib, followed by a posterior acoustic shadowing. M mode allows the display of echo data from a single ultrasound beam over time. This is illustrated by the bright yellow dotted line in the image. In this case, the heart continues to beat and data is collected from this single beam over a brief time period. This data is displayed as shown in this slide. M mode is valuable in dynamic imaging, such as cardiac wall motion or valvular leaflets. Doppler ultrasound is based on the Doppler effect, which refers to a shift of frequency in the ultrasound wave caused by a moving reflector. As illustrated earlier in this lecture, sound is high-pitched or high-frequency as the car approaches an observer, and sound is low-pitched as the car leaves the observer. When scanning in Doppler mode, several factors can affect the amplitude of the signal received by the transducer. The picture on this slide illustrates a blood vessel being scanned in Doppler mode. As the velocity of the blood flow increases, a larger amplitude signal will be received. Additionally, one must pay attention to the angle of insonation. This refers to the angle between the ultrasound beam and the direction of flow. Notice in the diagram that as the transducer is moved along the course of the blood vessel, the angle of insonation changes. In position A, the transducer beam is directly parallel to blood flow, which is moving towards the probe. Hence, a higher positive amplitude signal is received. In positions B and C, the transducer beam is progressively less and less parallel with flow, resulting in a lower amplitude signal. Finally, in position D, the beam is again parallel to blood flow, however flow is now moving away from the probe, resulting in a negative high amplitude signal. Color flow, or color Doppler, is a mode in which ultrasound machines determine the velocity and direction of flow, and then color encode the area of interest using the Doppler effect. The blue and red colors represent whether flow is moving towards or away from the probe. Note that these colors do not represent the nature of the blood vessel. For accurate flow, the transducer is placed parallel to the vessel along its long axis, and the angle of incidence used should be 0 to 80 degrees. If the ultrasound beam is directly perpendicular to the flow, color Doppler information may not be displayed. Pulse wave or spectral Doppler is a mode in which dynamic data is gathered from a certain point over time. An example of this is visualizing the character and velocity of flow within a blood vessel. A sampling gate is used on the machine to gather data at the point of interest. Power Doppler is a very sensitive mode of Doppler imaging, which is 5 times more sensitive than color flow mode. This is useful to determine the presence or absence of blood flow in low flow organs. We will now discuss image acquisition. There are 3 primary imaging planes in the body. First, the transverse plane is achieved by orienting the probe marker to the patient's right side. The sagittal plane is achieved by orienting the probe marker to the patient's head and aiming the probe from front to back. The coronal plane is achieved by orienting the probe marker to the patient's head and aiming the probe right to left. An important concept to keep in mind is the imaging plane of an organ or structure in the body may vary from the body's imaging plane. An example of this is the long axis of the portal vein, which runs its course at an angle. In the diagram above, the portal vein is demonstrated draining into the liver. Note that if the probe is placed in a sagittal imaging axis, the portal vein would be visualized on the ultrasound machine in an oblique view. If the probe is rotated, however, the portal vein can be visualized in a longitudinal axis. This slide reinforces the same concept, that the body's imaging planes, shown on the left, differ from the planes of the structure being scanned, which are demonstrated on the right. Resolution is defined as the ability of the machine to distinguish 2 structures that are close together as separate. The types of resolution can be categorized into axial, lateral, and temporal resolution. Axial resolution refers to the machine's ability to distinguish objects that are close to one another in a fashion that is parallel to the ultrasound beam. This is dependent on the pulse length and is illustrated on the left side of this diagram. Notice the 2 separate structures in the scanning field that are close together, and they are in the same plane as the ultrasound beam. If the length of the ultrasound pulse is too long, the machine will not be able to distinguish the 2 structures as shown. Using a higher frequency will improve axial resolution. Lateral resolution refers to the machine's ability to distinguish objects that are side by side or perpendicular to the ultrasound beam's axis. This is dependent on the beam's width and the depth of the image, and is illustrated on the right side of this diagram. Notice the 2 separate structures in the scanning field that are close together, perpendicular to the ultrasound beam axis. If the beam width is too narrow, the machine will not be able to distinguish between the 2 structures as shown. Wider beams typically diverge further in the far field, and any ultrasound beam diverges at greater depth. Therefore, lateral resolution is best at shallow depths and worse with deeper imaging. Temporal resolution is the ability to precisely position moving structures from instant to instant. The focus is the level at where the ultrasound beam is the narrowest. Note the other zones of the ultrasound beam. The dead zone has poor resolution and is closest to the probe. The far zone also has poor resolution and is located in the zone furthest from the probe. When scanning, ensure that the focus is at the level of the structure you are trying to image. An optimal image is obtained by adjusting the focus at or slightly beyond the structure of interest. It is important to avoid placing the structure of interest in the far zone. Images or regions of the image are described in terms of intensity of the returning echoes. A region that is anechoic displays no significant echoes and appears black on the screen. Oftentimes, anechoic structures are fluid-filled organs. The term hypoechoic is a relative term which refers to a structure that is a darker shade of gray compared to its surroundings. The term hyperechoic is a relative term which refers to a structure that is a brighter shade of gray compared to its surroundings. If a structure is isoechoic, they are of identical echogenicity to the surrounding area. Artifacts are a normal occurrence in ultrasound. The term refers to any structure in an ultrasound image that does not have a corresponding anatomic tissue structure. To understand artifacts, one must consider the basic assumptions that an ultrasound machine makes when creating an image. The four primary assumptions a machine makes are: 1. Attenuation of the ultrasound beam is uniform at a constant rate as it travels through tissues. 2. The ultrasound beam is infinitely narrow and has a uniform width throughout its course. 3. The velocity of ultrasound in all bodily tissues is 1,540 meters per second. 4. The ultrasound beam always travels in straight lines to a reflector and then travels in a straight line back to the transducer. It is common knowledge that these assumptions do not always hold true. However, keeping these in mind while scanning will help a sonographer avoid pitfalls and identify artifacts. It should be noted that not all artifacts are considered bad and can be helpful in certain situations. We will now discuss some of the more commonly encountered artifacts. Reverberation refers to ultrasound waves that bounce back and forth between two highly reflective surfaces. In the diagram, the transducer acts as another reflective surface to the returning echo. This echo will then be re-reflected and retrace itself, resulting in an artifactual image identical but twice the distance from the transducer as the real image. This video is an example of lung ultrasound, and the bright line seen in the near field represents the pleural interface between the visceral and parietal pleura. The pleural interface is a highly reflective surface. Note the reverberation of this interface in the deeper fields. Recall from earlier in the lecture the difference between reflection and scattering. The term reflection refers to a wave being bounced off a smooth or specular surface. Scattering refers to the wave encountering a rough surface, causing waves to reflect in various directions. Mirror image artifact occurs when the mirror image of a region is seen beyond a strong specular reflector. In the example image, a strong reflective surface shown is the diaphragm. Note the appearance of the liver below the diaphragm. Above the diaphragm, one would expect dirty shadows from air in the lungs. However, instead, we see a mirror image of the liver in this region due to the diaphragm's strong reflective properties. Posterior shadowing occurs distal to a dense object in the field of view. The artifact results from a loss of ultrasound beam energy distal to a dense object. As illustrated in the diagram, the dense structure, depicted by a white oval, reflects back a majority of the ultrasound energy. Distal to this structure, we see a loss of echoes causing the distal region to appear dark. This is demonstrated in the image, which is a scan of the gallbladder containing a gallstone, followed by posterior acoustic shadowing. Posterior enhancement occurs as a result of an abundance of ultrasound beam energy. Typically, this occurs distal to anechoic structures, which reflect back very little energy to the transducer. As illustrated in the diagram, distal to the anechoic structure, we see an abundance of residual beam energy, which causes the distal region to appear hyperechoic. This is also demonstrated in the image, which is a scan of the urinary bladder, followed by posterior acoustic enhancement. Edge shadowing artifact refers to the thin shadow that appears behind the edges of cystic structures. This is thought to occur due to sound waves encountering the cystic wall at a tangential angle, causing the waves to refract. A shadow appears distal to the walls of the cystic structure. In both examples shown, the artifact occurs at the edge of the gallbladder. One can attempt to reduce this artifact by changing the angle of the transducer. The gain refers to the overall strength of returning echoes. While this is technically not artifact, an image with improper gain may result in an inadequate image. Gain can be thought of as an amplifier. The 3 video clips demonstrate the view of a gallbladder being scanned at varying levels of gain. We will conclude this introduction lecture with a discussion of ultrasound bioeffects. As mentioned previously, ultrasound, like all sound waves, is a form of mechanical energy. The output of energy will vary with the mode being used. For example, the Doppler modes result in more energy output compared to B mode and M mode. There is no ionizing radiation involved in diagnostic ultrasound. The thermal index is used as an indicator to determine the risks of tissue temperature rise. The mechanical index is used as an indicator of risk to soft tissue when ultrasound waves are absorbed and the effects of tissue compression and decompression. Both indices are typically visible on the screen during imaging. The potential benefits and risks of each examination should be considered. The Elara principle should be observed when adjusting controls that affect the acoustical output and by considering transducer dwell times. This concludes our introduction lecture.